All right, so let's continue. So we stopped last week with the settings, I believe. So let's do, did we do intubation, the airway and everything? Not yet.
Yeah, we did.
So we're on just the mechanical ventilation, right?
Yeah, and
We do up to
you
flow
told us
rate.
to do flow rate.
Yeah, we
Yeah.
left off at PEP.
Okay, so that was the settings. All right, so let's start now with the ventilation modes. One thing to remember is ventilators do not cure the underlying disease. So the main purpose of mechanical ventilation is to support ventilation. So patients are no longer able to supply their own oxygen needs via spontaneous breaths. So the patient now requires ventilation in order to remain alive until we solve the underlying problem. Okay, so that's all here in both paragraphs. So that's the purpose of mechanical ventilation. We did the intubation already last week, I believe. So let's go to the modes. Okay, regardless of the type of ventilators, which we are not testing, we're not testing the type, we're testing the mode. There will be differences in what each hospital uses, but regardless of the type of ventilator, they're all capable of the same modes. Your textbook only describes 2 volume modes, and then we have 1 pressure mode, which is under the weaning part. Before we go into the volume mode, let's discuss. You can see the whiteboard, right?
Yes, sir.
All right. The mode used for a patient is all about work of breathing. So the doctor decides based on the patient's particular needs, the patient's particular underlying condition, who does the work of breathing. In order to appreciate assist control and SIMV, which is synchronized intermittent mandatory ventilation, let's talk about control mode first. There is a control mode. You can only see this in the OR. So this is used in patients receiving general anesthesia. Reason is, during surgery, we don't want the patient moving, right? We want them to be completely still. So it's not enough to just give them anesthetics and pain medication. They will also be given a muscle paralyzer, which I'm referring to neuromuscular blocking agents. So this will temporarily paralyze the patient, including the breathing muscle. So the diaphragm is also paralyzed. So the patient's pretty much not able to breathe. So that's why we intubate and put them on a ventilator. The mode used is control mode. The vent is completely in charge. The vent gives the breath, gives the frequency, gives the tidal volume. Patient is not able to breathe. So, and in order for this to be possible, you have to paralyze the patient. Because otherwise, imagine if you are right now. So if we put you on a ventilator and just maybe sedate you. Sedation means you can still breathe. So imagine if you have no control over breathing. A machine is breathing for you. When you try to breathe, you're gasping for air because you won't get one. You have to wait until the machine gives you one. Okay, so how would that feel?
But
Would that be comfortable?
no,
You
No.
assured, relaxed when you're in that scenario?
no.
That's the most scariest thing in the world. Okay, imagine depending on a machine and you're unable to breathe whenever you want. Okay, so you can understand why this is only used in a patient undergoing surgery, which a patient who is paralyzed. okay, at least for temporarily. So you will see control mode used. So on the floor, regardless of what the cause was to intubate the patient, everybody starts, at least almost everybody starts at assist control. So this is a volume mode. Volume mode has two settings, two preset settings. So we have the tidal volume and the frequency or the rate. These two are preset in any volume mode. So you have SIMV or assist control. Assist control is also called CMV, continuous mandatory ventilation. It's more commonly called assist control, and then this one is or AC. Okay, on the vent you may see AC, and then this one SIMV. So most people started, let's say whatever the reason is, you decided to intubate the patient, they'll be put on AC initially, because this is the most ideal, because it has two, like I said, two preset settings. So there's a preset tidal volume and a preset frequency. So let's say for instance in AC, we put the tidal volume at, let's say 400 ml, and the frequency at, say 12 per minute. So if the patient breathes, the patient's given a breath. So if it's 12, that means every how many seconds does the patient receive a breath?
15.
Every,
Oh, 5 seconds.
okay, every 5 seconds. All right. Okay, so let's say patient gets a breath here. Psst. All right. It doesn't go to 0. Remember I mentioned PEEP last week? So PEEP will keep it from going to 0 pressure. So there will be anywhere from 5, 10, 15 centimeters of water pressure at the end. So there's no 0 pressure at the end of exhalation. So 5 seconds later, patient gets another breath here. Psst. All right. And so on. If a patient decides to get a breath, take a spontaneous breath, it will be displayed on the vent as a negative pressure. However, when the patient initiates that, and there will be a setting called the sensitivity or the trigger. Sensitivity is, the default is I think 0.05 centimeters of pressure. It depends. The doctor may adjust this. If the patient is really weak, he may put the sensitivity higher if the patient's unable to generate that much negative pressure. So when the vent senses the negative pressure, it will give the preset tidal volume, meaning the patient cannot determine or has no say on how much tidal volume they want. All the patient does is they initiate it, they try to take a breath like this, so it goes negative, vent senses the negative pressure, it will give the patient the preset tidal volume. With me so far? So again, if the patient breathes in between ventilator delivered breaths, initiate their own, they can do that. However, they cannot determine the tidal volume. The vent determines it because it's on AC mode. That's what it's supposed to do. The patient can initiate the breath. They will be given a breath. That's why it's called assist. But the vent will assist the patient's breath, but maintains a sense of control, whereas the patient can never get less than 12 breaths per minute. Regardless if the patient breathes or not, patient gets a minimum of 12. So there's a good thing here and a bad thing. Good thing is that one I just said, there's no way the patient will be hypoventilating because there's a minimum number of breaths given per minute. The patient, though, can hyperventilate because remember, they can take spontaneous breaths. So let's say the patient takes another 12 of their own. So that's 12 preset plus 12 spontaneous breath. How many breaths is it total per minute?
24.
Is 24 normal?
No, that's technique.
That's already hyperventilation. So one problem here is the patient could potentially go into respiratory alkalosis. So as the patient gets better, you will see it based on the ABG. So during the course of your ABG checks, you'll start seeing a pattern of respiratory alkalosis over several hours. Then that means the patient is now, are they getting better or are they getting worse?
They're getting better. They're getting more spontaneous
Yeah,
breaths.
they're taking more spontaneous breaths, and you can see it on the ABG. You can see it on the ventilator record that how many spontaneous breaths they've been taking. Another disadvantage is, let's say the patient, because the patient has no idea when they'll get the vent breath and when they're taking a breath. There could be a possibility that, so let's say here, they took the breath at around 7 seconds. And then it's time for the ventilator breath here, correct? So they'll get another breath here. If the patient takes a breath too close to the next scheduled one, let's say they take it here, and the vent senses that, vent gives a breath, psh, before they can take a full exhalation, it's time for the vent scheduled breath. So without completing the exhalation, they might get another breath here. So try imagining how that will feel. So you can't see me, but imagine. Okay, so I'll go on my way to an exhale. I get another breath. So I'm just starting to empty my lung here, and then the damn vent gave me another breath. So this is what we call breath stacking. So you have one breath on top of another breath. So that only not causes barotrauma, but also volutrauma. Okay, so you have two breaths pretty much almost on top of each other. So this is another disadvantage of this mode. So this means, does your patient stay on the same mode the whole entire time?
No.
No, the patient must be evaluated every hour routinely. Is the patient still receiving appropriate therapy? Is the AC still appropriate for the patient? We typically don't worry during the first 24 hours, maybe up to 36 hours, but after that, the patient should get better. So we typically, of course, that's not always the story. Patients can go bad, but we do expect, they're in the hospital, we expect them to get better. So most patients do get better. We just need to monitor for these. So monitor ABGs. We see respiratory alkalosis, then that means the patient is taking more breaths. Or for this one, patient usually goes restless here. Patient may become restless, agitated, and if not appropriately sedated or you have no bite block, the patient will bite the ET tube. Okay, because they're so uncomfortable. This is very uncomfortable. Imagine this feeling right here. So the patient might start fighting with the ventilator if that happens. Meaning it's occasionally, it doesn't happen all the time, but it does happen. So just monitor your patient if that happens. It's just an unfortunate event that that occurred. Okay, so let's go to your textbook. So that is what it means here. So the patient on a AC mode has a preset tidal volume, preset rate. If the patient doesn't breathe, no problem. the ventilator gives them the minimum preset rate, preset tidal volume each time. If the patient though takes their own breath, the ventilator delivers the preset volume, meaning the patient can breathe, can have more breaths than the preset rate, but never below the preset rate. Does that make sense? Meaning they can always increase it if they want, but they can never get less than what's preset. And as already mentioned, this is the disadvantage. Patient could go hyperventilate, might start hyperventilating as a result, go into respiratory alkalosis. So again, it means you have to continue monitoring the patient the whole time. It's never a case of set it and forget it. All right, so let's say the patient did get better. So the next mode used if the patient starts having these frequent hyperventilation episodes and frequent, respiratory alkalosis episodes on the ABG, doctor can do two things. If he really believes, so let's say he'll take an x-ray, let's see, gets an x-ray, and on the x-ray, the lungs look better. Okay, there's less fluids in there, the lungs are expanding, for instance. He may decide, oh, okay, the patient is getting better, let's try him on SIMV. Of course, if he's not convinced that the patient is getting better, he will just tweak the settings on the vent. Let's say patient goes into respiratory alkalosis, maybe he'll drop the FiO2 maybe, or rarely will no doctor will drop the respiratory rate on an AC mode below 12. Okay, it's just not safe. So they're better off if they really believe that the patient is breathing more and these breaths are what's causing the respiratory alkalosis, then they'll put them on SIMV. Obviously, the patient's better, we can start putting them on SIMV. SIMV can be a weaning mode. Okay, that's the benefit of SIMV because it can be used as a sole ventilatory mode as well as a weaning mode, because we can drop the rate here, okay, from 12 to 2 if used as a weaning mode. Okay, it's clear here. Only if you're using it as a weaning mode, then we drop the preset rate. Okay, all right, so let's illustrate that one. SIMV is, like I said, is also a volume mode. So it has tidal volume and preset rate. Almost the same. However, the main difference here is in the tidal volume. When the patient takes their spontaneous breath here, in SIMV, the vent will not give them the preset tidal volume. So if the patient takes a spontaneous breath, so let's say this one here is a spontaneous breath by the patient. When the trigger is set, the vent will not give a breath. It will allow the patient to take, okay, go ahead, take a breath. I'll leave you alone. So the patient can take less than the preset tidal volume, or they can take more than preset tidal volume. So the patient here is more comfortable because they have a control over their own tidal volume with every spontaneous breath. They will not get the preset tidal volume unlike in assist control. So if this patient truly is getting better, this is now a more comfortable mode. Okay? So the vent is a computer. So the vent can analyze a pattern between the patient's breath. So it will not give the patient these stacked breath, because it will now sync with the patient's ventilatory pattern. So if they see a pattern, oh, this patient is now taking 12. Last minute he was taking 6. Now he's getting 12. So they will not give. So if it's too close to the scheduled breath, the vent won't give that breath. So that's why they call it synchronized. Okay, so the ventilator will establish a pattern. So it will analyze the patient's spontaneous breath, establish a pattern, and then sync with that pattern. Meaning it will analyze how many seconds is it between the patient's breath. If they see a pattern that they can sneak it in, they'll give a breath right there. But if not, they'll allow the patient to take as many breaths and as much or as less tidal volume as they want. Any
So,
questions?
Professor, I have a question, please.
Uh-huh.
So in the SIMV, if the preset rate is, let's say, 12, and then the patient takes another 12, so does it still count as 24, or?
Say again, count as 24? No,
24.
the vent won't give the preset rate. Yeah, because like I said, it will sync with the patient's ventilatory pattern. So here, unlike
So what will,
okay, go ahead.
I'm sorry to interrupt, but what will the final rate be? The actual rate will be? Like,
Okay,
would it be still 12, but all spontaneous?
Okay, it can be, because remember, this one is a volume mode, so it has a preset tidal volume, preset rate. As long as the patient does not fall below the preset rate, it will allow spontaneous breaths.
But up to what? Because now the patient is controlling the rate as well, unlike the other one, the AC.
Okay. There's something we call minute ventilation. Did I mention ventilation? It's really simple. It's the rate times the tidal volume. So how many breaths per minute times tidal volume, that is your minute ventilation. So as long as the patient meets minimum minute ventilation, that's fine. The vent won't work. But if the patient fails to meet that minute ventilation, then it will give the preset rate and preset tidal volume to meet the minute ventilation. Right?
Okay, thank you.
Because one thing, again, the patient's lung compliance changes, right? So just because there's a preset tidal volume doesn't mean the patient will get the preset tidal volume. So on the screen, you'll see the and then see right beside the tidal volume, how much did the patient's lung allow? Does that make sense? Because the patient will
yeah.
Did you lose me? Okay, sorry. Just because the patient receives preset tidal volume, or just because you set one on the ventilator, doesn't mean the patient will get that preset tidal volume. The lung can only get so much. So either trigger the high pressure alarm or low pressure alarm, whichever the case is. If that, but the vent does allow, let's say, usual tidal volume is around 400. The patient may get around 350, 380, but that's not a significant difference. So that won't trigger any alarm at all from the vent. Okay, so just two basic volume modes. I'll talk to you because the pressure mode is under the weaning. I'll just talk about the pressure mode later under weaning. And when as I mentioned earlier, when used for weaning and not as a main vent mode, the doctor will order a gradual decrease of the preset rate. So together with the respiratory therapist and the nurse, the doctor will say, okay, so is that begin weaning protocol. Okay, so they'll do the dropping of the respiratory rate in every 2 to 4 hours, and then until the patient, then in between, because we always draw ABG within 30 minutes of a change. So 30 minutes after you change the rate, we draw ABG, and if it looks good, it's normal, then we proceed with the weaning, and we'll discuss also the extubation procedure later. Other modes are BiPAP. I think I mentioned this last week with the setting. So a ventilator can function as a BiPAP. Already did the settings, so when caring for a patient with on a ventilator, as stated here, so regardless the alarm that goes off when you enter the room, check your patient first, and the patient checks out fine, go to the check vent. It's easy for patients to go into ICU psychosis. This is mainly due to sleep deprivation. So you can imagine how busy and how noisy an ICU can be. The most they'll get probably is 2 hours straight sleep before a nurse comes in, either draws blood or checks them out, so that wakes the patient up. We try our best to keep it at a minimum, but we have a job to do, unfortunately. So they will have sleep deprivation regardless. We try to keep it at a minimum. So we have a quiet time at night, which, I mean, at least we do our best. Some hospitals will modify the setup in the ICU. We've tried putting glass panels on around the nurses station to keep the sound waves from going out into the hall, into the patient's cubicles. So it just bounces around. We have these sound decibel monitoring things on the walls to keep our voices down. We try to decrease the volume on the minimum volume on the ventilators and also the IV pumps, just to keep noises down as much as possible. This does resolve on their own, but consider ICU psychosis when the patient starts. It may not always be hypoxia. It could be delirium already. These are natural consequences the longer the patient is on a ventilator. Remember, this is positive pressure ventilation. This is not the same as our body, which are negative pressure ventilators. We naturally take in a breath passively. Our diaphragm contracts down. Air is sucked into our lungs passively with no effort, no pressure, because the pressure inside our thorax is negative compared to the atmosphere, which is positive pressure. We did have negative pressure ventilators during the first few models that were developed, because they tried to mimic it, and then what resulted was the only way to do it is to wrap the patient in a cylinder, either a steel cylinder with only the patient's head sticking out, and then we have tubes sticking out that big cylinder and sucking the air out, causing a vacuum, mimicking the diaphragm, so that air is sucked into the patient's lungs passively. that proved to be very impractical, because imagine if you have to clean doo-doo, for instance, or let's say assess the patient's lung sounds, then you have to interrupt the therapy, open the cylinder and do your thing, and then do the whole thing over again. And the alternate was like a suit. It looked like a body bag, but same thing, the patient's head is sticking out, the rest of the body is inside a body bag. And that was also a negative pressure ventilator, so you can easily see that didn't work out very well. So they got rid of that, and now all our ventilators are positive pressure ventilators. Because of this, there will be increased, more than normal, there will be increased intrathoracic pressure. So that will put a lot of pressure on the mediastinum, causing compression of the heart more than usual. Not only the heart, but also the large vessels, the superior and the inferior vena cava, causing decreased cardiac output, and then increased workload of the heart. So you can see why patients who have these disorders to begin with, before they have been intubated and put on a ventilator, it will be easy to exacerbate these conditions and may cause weaning to be extremely difficult. We will talk about the complications later. These will be mentioned a few pages later. Monitoring patients' response. So as mentioned earlier, this will include listening to patients' lung sounds, doing your ABG draws. It is a nursing responsibility because these sick patients will have an arterial line. So there's really no need to call a respiratory therapist to do an arterial stick. So you can draw your arterial blood straight from your arterial line. Please refresh yourselves on the ABG values interpretation, because they will be part of the questions on the vent. Don't go crazy. There will only be a maximum maybe 4 questions on a patient mode and setting. Reason is you typically don't get so many of these on the NCLEX. Because the patient is sedated, so you won't see mental status. If anything, you'll just see restlessness maybe. So your basic assessment data will come from your ABG. So whatever thing you do on the settings or modes on the vent, it will be reflected on the ABG 30 minutes later.
And then, Professor, if we see that something's wrong, we just notify the physician?
Yes, but you need data to report though. You just can't say, hey doctor, can you check your patient? Why? Something's wrong. I don't know what it is.
Understood.
All right. So here's the reason again, because you're the one at the bedside. We do have the RT, but respiratory therapists are outnumbered. You may have one for the entire floor. That's a heavy assignment already. You have one RT for the entire ICU. Or sometimes at night shift, they may share ICU with another floor, but never ER and ICU. That's the RT will never come back tomorrow if you give them that assignment. Although they help each other out, there may be 2. They're lucky if there's 3 or 4 RTs during the night shift. They do help each other out because the floor where you're assigned may not have anything going on besides the nebulizer treatments. So if that's the case, then they go help out. They buddy up with the other RT. Here's a critical rescue reminder. if you have something wrong with the ventilator and you can't figure out what it is, rather than having the patient miss out on breaths, it's better to disconnect them from the ventilator and then just give your breaths manually with a bag valve mask until someone can figure out what's wrong or until you can get a new one as a replacement. If the patient is already starting to be weaned but is still ventilated, obviously they can't talk, so provide the means for communication. Until then, again, a reminder is do not talk as if the patient is not there. I do that often. I mean, I didn't intend to, but you know, because you have a patient who's unconscious, you tend to just talk as if nobody was there. They do hear it, and you might get into trouble depending on what you said. Okay, especially if it's about the patient. I remember one case we were cleaning a female patient, and then on turning, the nurse said, you know, when the perineal area was exposed, and then the nurse commented, "Oh, that's a lot of bush." And then when the patient was extubated, the patient remembered, okay, what she heard. Of course, there was no, you know, the patient never knew which nurse that is, but there was um, I mean, the nurse involved just, you know, came clean anyway. You know, I didn't mean that. You know, just because rather than keeping quiet, and then we're gonna find out anyway. So the nurse came clean. So that's a frequent reminder for all our orientees when we have, you know, orientation. We remind them of that. I've had students too who become my colleagues. You know, they graduated and now they're working in the same hospital, became charge nurse, the supervisor, and now one of them, Dan, is already a nurse practitioner. He was a 2010 graduate, so he worked hard. So he's a critical care nurse practitioner. So I remember his first day. He said, you know, why did I apply in ICU? I'm never gonna come back next day, but he did anyway. And then next thing you know, he's grown comfortable, and he was good looking. So we used him a lot for our TV commercials because we were competing against 3 other hospitals in Tri-County area. So he was our guy, and he had that charisma. You know, he was tall. He had a good charisma. I miss Dan. All right. We already mentioned this, if you remember last week, about condensation settling in the vent circuit. Yeah, you remember this?
Yes.
Okay.
Yeah.
And this is another reason for that. So do not allow that to go back into the cascade nor go to the patient. All right, so alarms. We will only, because your textbook only talked about 2, we'll only do 2, high pressure and low pressure alarms. If you go down the list for high pressure, what is the patient doing in all of these? What is it causing between the patient and the ventilator? Because remember, you have the patient and then you have the vent. Between them, you have a circuit tubing. Then, of course, you have the airway. So what will happen if there is increased mucus in the airway? The patient coughs, gags, or bites the tube. Patients fighting the ventilator. airway, we're talking about the trachea here because you have a plastic airway in there. It will cause inflammation and may decrease airway size. You get a pneumothorax. You get a displaced tube. The tube is into the right mainstem bronchus. It's obstructed by either the condensation in the circuit, or the patient size, or the lung compliance changed. Obviously, it decreased. So what happens between the ventilator and the patient here in all of these conditions? What has developed? When you bite, have an obstruction, a displaced tube, decrease airway diameter. So what do you, give me one word.
Resistance.
Okay, there is increased resistance in all of these cases. So the ventilator senses that increased resistance. Somehow it's working harder to deliver the breath to the patient, caused by any one of these. All right, so there is increased resistance here. That's why it will trigger a high pressure alarm. It's because that's exactly what's happening. The vent is sensing a high pressure or higher resistance with each breath delivery. And so questions on the test will either be, I'll give it to you. This is a very nice select all that apply question. I'll give you a list of causes and identify whether it's high pressure or low pressure, or just say the ventilator's high pressure alarm is going off. Which are possible causes? Or that's assessment. Or a question could be interventions. Which of the following actions will the nurse take? So it's either first or second column. Any question? I mean, they're self-explanatory. That's what you do. If that happens, that's what you do. That what happens, that's what you do. All right, let's go to low pressure. So this is the exact opposite. So what happens if you have a leak in the circuit, the tubing has a hole, or maybe it's disconnected from the patient, or you have a cuff leak in this is referring to the endotracheal tube. So the cuff inflation pressure is low. So you have a leak of air going around the tube, or the patient stops breathing. What's happening between the patient and the ventilator? There is low resistance or low pressure. So there's not enough resistance between the ventilator and the patient. Another cause not listed here is if the patient extubated themselves, they pulled the tube out. Somehow your propofol is empty. You have no sedation running anymore because you ignored the beeping pump. It was saying empty. It's been an hour now, so the patient's awake, and then it's a scary scenario. Patient's awake. What's going on here? And then they pull the tube. Okay, so there's no more resistance. And again, here are your corresponding actions. Questions on exam will be the same. I'll either ask you the cause or your interventions. Any questions on alarms? All right, we looked at this last week, right? Indications for suctioning when we went to chapter 28. Yeah?
Yes, we did.
All right, so here are the other indications. There are probably one or two that was mentioned here, wasn't mentioned in chapter 28, or vice versa. I know there was one or two that was a little bit of difference. Okay, so this was on the best practice already, so they repeated it again. So this is part of ensuring proper tube placement as well as proper cuff inflation. Now, part of the bundle, because one of the preventable complications of mechanical ventilation is pneumonia. So this ventilator-associated pneumonia occurs within 48 hours from intubation. So all patients who've been intubated for longer than 48 hours are now at risk for VAP. Because of that, we have a bundle, because this will drop our revenue. This is not good on reimbursement. When you send the reimbursement, you spend money on ventilator-associated pneumonia, it drops your revenue. So we have to prevent it in the first place. Plus, the fact that it will affect your patient's outcome. Patient might not make it. Patient will die because of the pneumonia. So our bundle is right here. No, right here. But please go back here because the PPIs are listed here. PPIs are part of the bundle. So the bundle is head of the bed 30 or higher, oral care every 2 hours, and then brush the patient's teeth every 8. Also prophylaxis, again, the choices are here. We have H2 receptor blockers and PPIs. And we have preventing aspiration. This is on top of the head of the bed elevation. This is also referring to the subglottal suctioning. Remember the area above the ET tube cuff. You know what I'm talking about? Where the cuff is inflated, the area above the cuff.
Yeah, there will be accumulation of secretion.
Yeah, we call that the subglottal area. There are secretions there also, which we cannot reach with our yanker, okay, because that's too deep. So make sure you also suction that with a suction catheter. So you occasionally you go drop it down there, but especially if you before you deflate the cuff, before you extubate the patient, that subglottal area must be suction. We do have high-low evac tubes, but I don't know why they don't use it as a standard. A high-low evac tube, instead of having 2 lumens, most ET tubes have 2 lumens, one for the balloon for the cuff, and then one for the airway. Now there will be a high-low evac tube has 3 lumens. The third lumen is a bunch of holes above around the subglottal area, allowing you to suction the subglottal area without shoving a suction catheter down the patient's throat. That is very convenient because all you do is just switch the suction to the subglottal area, and that will suction that area for you. Very convenient. And of course, the last in the bundle is your pulmonary hygiene. So turning the patient, did I mention we can turn the patient prone? Yes, we did, right? Okay. All right, let me see if I missed anything here. All right, so on top of the pneumonia, we have other complications here. Barotrauma from excessive pressure, barotrauma pressure, volutrauma. This is usually from, either one would be from a displaced tube or a patient's lung compliance changes. So if they have a decreased lung compliance and we did not change the tidal volume, or we did not pay attention to the high pressure alarm, so these two will result. Between these though, these are not very common. Acute lung injury was mentioned. Remember, this one will cause ARDS. So a ventilator can cause lung injury as well. So this one obviously is direct lung injury caused by the having the airway and the ventilator. All right. The others are self-explanatory. The longer the patient stays sedated, there will be muscle deconditioning. Please realize that this is not only the skeletal muscles, this will also include the diaphragm. So this will delay your weaning as well. So that again, the longer the patient stays on the vent, the harder it will be to wean them off of it. Same thing for ventilator dependence. Again, the patient, the longer they're on it, the lazier they become, especially the respiratory muscle, the diaphragm. It weakens it. Okay, because remember the diaphragm can be flattened because of the high intrathoracic pressure. So because of that flattening, because it shouldn't be flat, it should be curved, right? If it gets flattened because of the positive pressure ventilation, that will weaken the diaphragm, causing ventilator dependence. So our goal always is to wean them as soon as possible, especially COVID patients. Weaning. So we did our care. The patient now is ready for weaning. I mentioned earlier, SIMV is used. This is the T-piece, meaning we just disconnect the patient from the vent. So they're from the T-piece. We had a picture of the T-piece earlier. 635. Where's that picture? I can't find the picture anymore. Maybe it's up here. I don't know where it is, but it's literally a letter T. T-shaped adapter we put on the ET tube, and like a T. So it will have two. So it's a T tube. One side is for the vent, the other side is for the oxygen source. So that's the T-piece. So meaning the patient is weaned by taking them off the ventilator, but the patient is still intubated. So they're literally breathing through the ET tube. This is the other mode.
T-shirts, are you really cleaning that's just attached? It looks like
it's better. Okay, pressure support ventilation. This can be used also as a weaning mode, but it can also be added to SIMV, meaning while the patient is on SIMV, you can add pressure support. Now, this is a pressure mode. It is not a volume mode, so therefore, there is no preset tidal volume, there is no preset rate. The only thing preset here is pressure. So since there's no tidal volume, no frequency, does pressure support deliver a breath? Does this mode deliver a breath at all? No. This is not a mode that you would use on a sick patient. This is purely a weaning mode. It can't be used as a main vent mode. You can add it to a volume mode, but never on its own, unless you are weaning the patient. So it's only giving pressure. It has a preset pressure. So the thing that varies here, therefore, is the volume. The patient determines their own tidal volume, whereas the pressure is constant because it has a preset pressure. So this will support the patient's ventilation. So this would be good for weaning because the patient's not ready to be extubated just yet. They still need the ventilator. However, their breaths are more or less adequate, but the patient is still weak. The respiratory muscle, the diaphragm, is still too weak. We're not ready to take them off the vent just yet, but we need to just give them a little bit of push. So this will be kind of like an assistant. Like if you're at the gym, you know, where you're doing bench presses, there's a spotter there. So the pressure support is like a spotter at the gym. So this pressure support is just there to, there's no other term, to support the patient's ventilation. Okay, but no breath is given. It only gives pressure support. Okay, just helping the patient get that air in. All right, so this is a weaning mode. Obviously, for this to work, the patient will have to be taken off sedation. The sedation will just delay the weaning process. Plus, you really want the patient's respiratory effort to increase, and that will be weakened or impaired when the patient is sedated. Extubation, it's pretty simple. We have already done our spontaneous breathing trials, either by PSV or TPs. The patient is doing well on the ABG, so we're getting ready to take it out. So first thing, of course, you explain it to the patient, what we're doing, because they need to cough right afterwards. So when ready, we hyperoxygenate the patient. Don't forget to suction again the subglottal area. Otherwise, they'll choke on those. We don't know how old those secretions are, and then the patient will get pneumonia. So hyperoxygenate, suction the tube right before you deflate the cuff. Okay, so suction it thoroughly, making sure there are no secretions sitting on top of the cuff, and then rapidly, as soon as you deflate the cuff with the syringe, and then you pull the tube. Should be easy. And then have the patient cough right away. Of course, you explain all these, what's going to happen. After you remove it, just, you know, encourage the patient, okay, cough, 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 and then they'll cough that out just in case, because right after you suction, of course, the tube is still there. It will trigger more secretions. So right after you suction, there will be more secretions again. So it's important that they cough right after you pull the tube out. And as expected, of course, there was the tube there, so there's inflammation. It will trigger secretions, so they need to do the coughing more frequently, okay, because of the, and they are exposed. You tell them to expect increased secretions, okay? So just give them the yanker, a clean yanker, you know, to help them suck the increased secretions. Then you monitor, especially for signs that the patient may need to be intubated. So that's obstruction, and these are your signs and symptoms. So if these are present, notify physician, patient may need to be intubated again. Questions? All right, that's it. Take a break. We'll come back at 7:15.